to discuss the fascinating topic of ICD-10 codes. And you may wonder why we are talking about this. I have with me two experts on the subject, Dr. Joel Wallskog and Dr. Irene Mavrakakis. And they have differing opinions on ICD-10 codes. So we've been going at it online, the three of us debating this topic. And so I thought we should all just meet face to face, albeit online, but at least we're looking at each other and we're going to have a conversation about this. And it's over vaccine injuries, how to code for vaccine injuries, and why coding is so important for the injured. So I'm going to let each of you introduce yourself and just give a very brief overview of why you are interested in this topic. We'll start with Dr. Mavrakakis. Irene, tell us what has you interested in this subject?
Well, first of all, Mary, thank you so much for having me on your show. And it's nice to see you again. And as well, Joel, thanks for having this discussion with me. And before I move on, I would be remiss in not saying to you how amazing you were during COVID mania tyranny and your bravery, and you were a beacon for truth and liberty. And there's a lot of us that didn't know you that needed you, and you just need to know that. So I think that's really important.
Thank you very much.
So thank you for that. So I'm board certified in anesthesiology and board certified in interventional pain and musculoskeletal spine conditions. And so over the years, vaccine injuries on the musculoskeletal and spine side found their way to my office. And my first vaccine injury case was a chief master sergeant at the local Air Force base who walked into my office somewhere in 2010, 2011 with a book called Vaccine A by Gary Massimito, talking about the vaccine injuries related to the anthrax vaccine, MF59, which is actually squalene, and its ties to Gulf War syndrome. So that book, which is nonfiction, Vaccine A, is very important. And I did read about it, but I didn't really fully understand all of it. And I can't possibly remember if I found a code for it. But I did take him at his word and watched him slowly get sick over the years. And a lot of the airmen from the Dover Air Force Base are mentioned in that book. And then it wasn't until 2012 when I was vaccine injured by the flu vaccine, which put me into recurrent anaphylaxis. And I was sick for over 8 years. And through allopathic, complementary, and other means, I'm about 95% better after 8 years of illness. And during all that time, various sorts of vaccine injuries have been found into my office, and with a local neurologist and some naturopaths, we've done our best to try and diagnose and treat them. And so we've been using various sorts of diagnosis codes, which are not perfect. They started with V codes, went on to E codes, and now they're T codes somewhere along in 2020.
Wait, hold on. What is a V code, an E code, and a T code?
So ICD-10 codes are codes that you use to make diagnoses. So in 2010, the ICD-10 code was a V code. In 2012, it was the E code series. In 2020, they became the T code series. And when you're in your EMR, NextGen or Epic or whatever, when you pick COVID vaccine injury or whatever you're picking, it might be the same T code, but the words of the diagnosis COVID vaccine injury are listed throughout that whole T code series. And I'll show some screenshots when we get into it. And we've been using that for diagnosis codes for many years, all these codes for treatments, IVIGG, plasmapheresis. So, and I know Joel submitted for us to get better codes, and better codes are always better, but people can get diagnosed for vaccine injury and they shouldn't even think that their doctor can't make that diagnosis, because even before 2012, from my research, you've been able to make the code diagnoses, and I've been doing it in my EMR for more than a decade, but it's oftentimes that the doctors don't know that they exist, and I agree more specific codes would be helpful.
Okay. And Dr. Wallskog, tell us why this issue is important to you.
Well, first of all, thank you for hosting this, Mary and Dr. Mavrakakis. Thank you for your story and thank you for being here. So, a little bit about myself. And again, I really like telling stories of myself, but I'll be brief. As a busy orthopedic surgeon, I specialize in joint replacement. I got one Moderna injection December 30th of 2020. And about a week later, I couldn't walk, started falling. It got quickly diagnosed with transverse myelitis with a lesion in my thoracic spinal cord. Since that time, my condition has really devolved or evolved for the worse. I've developed an autoimmune disorder, as my immunologist and neurologist say, is an unspecified autoimmune disorder, and I have regular issues with autonomic dysfunction. Now that being said, I was a busy orthopedist. No medical provider really likes coding. It's kind of the bane of existence, which is documentation and coding. And I remember in practice thinking, why is this important? But I delved into this quite a bit when after I got injured, and then became co-chair in November of 2021 of React19. React19 is, I hope some of your listeners know, is a grassroots science-based nonprofit advocacy organization for those Americans injured by the COVID shots. We are not here to debate the overall platform of the COVID pandemic, the subsequent response. But we are here to give those people hope and support. We have we have almost 40,000 now members of Americans injured by the shots. We also have 20 international partners, but we're the largest such advocacy organization now in the world. Coding. Why is coding important? Well, coding is important for a lot of different reasons. I mean, first of all, it provides clinical documentation. Okay, so if I see a person, let's say, as in my years of as an orthopedist, if they had a meniscal tear, I put a meniscal tear, which is an S83.2 code. But if I'm communicating with another orthopedist in the state of Washington, we both should be talking about the same thing. So clinical documentation is important. Billing and reimbursement. Dr. Mavrakakis, you definitely hit on the head where that's important for billing and reimbursement. I mean, right now we can talk about certain things like IVIG. If you don't have the right code, like a CIDP code, a lot of injured people need IVIG. They can't get it without the correct code. So we'll go back. We'll cover that a little bit more. Epidemiological research. Obviously, this is one of my big things. Okay, so Dr. Mavrakakis, you may use, say, a T50 code, but 99% of the other providers in the country probably don't even know that exists and what that means. Right? So unfortunately, what they end up doing, right, is using symptom codes, knee pain, leg numbness, and all of those cases, they get buried and are not, are not available for epidemiological surveillance. And again, we could talk about the T50 code, which I'm sure we will a little bit more. The T50 code is not specific to the COVID-19 vaccines. It is not. And that's why I'm through React19 have a proposal in to the ICD-10 committee through the CDC and the National Center for Health Statistics. That application went in December, and we should be considered for this new COVID vaccine injury specific ICD-10 code in the March meeting. And if accepted, that will go into effect next October. The other thing, other things that coding is important for: research, quality improvement, and regulatory compliance. So while I hate coding, just like most other providers, it's incredibly important. And for the people that are injured by the COVID-19 vaccines, even more so, because they can't get a diagnosis. And with a diagnosis, they can get recognized and acknowledged. And that's a huge first step for these people. We did a survey within our organization about a year after, in 2021 and 2022. The primary diagnosis of a survey of about 2,000 people was actually anxiety disorder. Okay, so 90% of people got a diagnosis of anxiety disorder as their primary diagnosis. That improved. A year later, we asked the same questions, and about 50% got diagnosed with an unspecified vaccine reaction. But again, I think we're at a point now where we need specific definitions of our syndromes, right? Because more specific diagnoses will lead to better diagnostics and therapeutics. And that's why my proposal and our React 19's proposal to the ICD-10 committee that's going to be reviewing our application is to start with a simple code like is used in Germany, U12.9. Okay, and that will identify that they have a COVID-19 vaccine injury and then have sub-diagnoses under that, such as CIDP, such as autoimmune disorder, such as antiphospholipid syndrome. So I think we're at a point to go way beyond using non-specific codes. And I hear you that non-specific codes can be used, but I think, again, like the T50 code that you talk about, really that leads to only, that's non-specific. It says just other viral vaccine. So a lot of other injuries could be dumped into that pile. And if we're going to go ahead and try to research, say, EPIC or some sort of database, how are we going to be able to do adequate research if the code isn't specific?
Yeah, so there's no disagreement from me that they need to have, of course, more specific codes, but I want to share my screen and demonstrate what a chart looks like in NextGen as our EMR system for my office, and demonstrate the fact that even though you pick the T50 code and then you can add the secondary diagnosis, I agree with your points. The point that I've been trying to make is that the biggest issue, or one of the biggest issue, is that doctors don't know that these codes have existed for 15 years or longer, and they need to put that diagnosis code in, and then you put the other codes related to the other conditions, and that's probably the biggest hurdle in my opinion. So let me just share my screen. This is taken from NextGen EMR system on some of my own vaccine injured patients that I have put these diagnosis codes in. Let's see, so we can share the screen. And then before I show current, I'll show briefly what it looked like in 2010 with the V codes. So can you see my screen, guys?
Yep.
So this is ICD. You can go back and look at ICD-10, which is just diagnosis codes, down to 2010. So the flu vaccine, for example, and it was interesting, they give you more numerical subsections. They were a little more specific as far as I can tell. We'll see. For flu vaccine, see, so Y59.0 influenza vaccine, that was in 2010, and then they have all the different codes, and then it's the digits, the numbers after the decimal point that distinguished amongst the vaccines. So this is from ICD-10.
Is there one for COVID?
ICD-10 2010 is not going to have a COVID vaccine injury because COVID vaccines didn't exist. This is the year 2010 is vaccine injuries for the year 2010. I'm just showing you 3 snapshots. So in 2010, based on my research, these were the current diagnoses for vaccine injuries in ICD-10. This is ICD-10 2012. Same idea, it's E949, and then the digits after the decimal point distinguish amongst the different types, smallpox, rabies, other. So this is ICD-10 or 9, it's 9 then, excuse me, 2012. The T50.5.B95A code became effective late 2020 as an adverse effect related to other viral vaccines. One of the other common conditions that are attached to it is chronic immune demyelinating peripheral neuropathy, which is the secondary code. I see a lot of those patients. They present as lumbar radiculopathy or sciatica, but they're actually vaccine injury. For people, you should consider CIDP in your brain as the peripheral nerve equivalent of transverse myelitis, and the autoimmune attacks the legs. It's responsive to plasmapheresis and IVIGG. On the categories of different vaccine injuries, it's on the hyperimmune IgG side of it. So neutralizing IV IgG and plasmapheresis have been treated. My local neurologist has treated many of these cases with me, and we detox through local naturopaths. So this code, for example, T50.B95A is very nonspecific. So I see a lot of SERVA for many years. SERVA is a payable vaccine injury on the vaccine adverse event reporting system. It's a shoulder injury related to vaccine administration. It's actually acute autoimmune brachial plexitis, or called Parsonage-Turner. It presents to the orthopedist as a frozen shoulder, but the code is only the same code. We've been seeing these for years. They're in the flu vaccine and they cause a lot of problems. And then again, like Joel said, we're stuck with this T50 code, right? And then we add other codes, like is it anaphylactic? Is it Guillain-Barré, brachial neuritis? And we have other codes that we can add to it, to Joel's point. But what I want to show you now is what an EMR chart looks like when you're putting in a diagnosis code. So if you're in any EMR in the United States, most likely and probably across the world, this is next gen. You search in your coding section, adverse vaccine, and it will give you various types of codes. And it does give you the code as listed as COVID-19. I'm going to scroll up for a minute. You see, it's all T50.Z95A. But when you add that code to your list, when you have your assessments in your EMR, it's going to have in the type section all the different subcategories, right? So it will put into your type set in your EMR that it's a COVID vaccine injury. But again, to Joel's point, it's the same T50 code. And it matters because of research purposes, right? So this is demonstrating, again, adverse mRNA, various types. One is more specific, but again, those are the different diagnosis codes that you put. This is an example. The rest of my chart, the patient has multiple diagnoses, and I put as another assessment CIDP, which is a different code, and they have the adverse effect of viral vaccines.
All right. Are you going to show us the EMR?
This is EMR screenshot. This is showing you, this is literally in the EMR. So then there's a history of vaccine-induced conditions, which is a D75.84 code. So what I'm showing is this is literally what you pick. This is in a patient's chart in NextGen. You put adverse mRNA and all these choices.
I don't think we're not seeing that though on our end.
You're not seeing this?
I see, it looks like something that's been written down, but no, I'm not seeing EMR.
I'm going to try again.
Okay.
Do you see it now?
Yes. Now I'm seeing, yep.
So I apologize for that. I think it was my user error.
Yep, that's different.
So adverse vaccine, and you see how it's all T50. It's the same code, to Joel's point, like I just said.
Mm-hmm.
But when you click on that, you know how you add it and it becomes part of your assessments, it will type out the different subconditions. But it's difficult for research if it's all using the same code. And you know what's interesting? Do you see how the V codes and the E codes after the decimal point had different subsections that allowed you to pick the different vaccines? It was actually better years ago, if you think about it. So here's another patient, and it has the different types of codes, like pertussis is T50.A15. The T50.59A is viral specifically, but it allows you to pick COVID-19 as something that's going to show up on your screen in the assessments in the EMR. To Joel's point again, it's still that same code. So his advocacy is well taken and important, but by all means, like we spoke before, the diagnosis codes that allow you to initiate treatment, because I've been doing this for many, many years, we are using these codes to get plasmapheresis and IVIGG for a long time, and other treatments. So this is just an example of one of my patients who has multiple codes for multiple diagnoses, and then I added the CIDP and the adverse effect of viral vaccines. This patient might have been a flu vaccine injury because I see them a lot too. And this is how it comes out, where you see the COVID vaccine induced other conditions, D 75.84. This is another example of how it can be typed differently into NextGen to give you more information. And when insurances request charts, they're going to see the whole typed out chart when it's a review. I mean, again, like Joel is right, we need better codes, but they do exist, and no one should be refused care or treatment because someone didn't look into the EMR to find the codes that have been there since before 2010. Another example of how you find the different types. This is a list of various types of codes that we have now. And the U code, to Mary's point, is not accepted in the United States, or you guys can talk about that more. I don't fully understand that, Mary, but you guys can talk about that. And this is adding some more like rickettsial vaccine, bacteria vaccines, and see how you have, it's all the same code for viral vaccines. Like
They
we just
have
discussed.
different descriptions, but basically it boils down to the fact that they're all under the same code. So you don't really know which, if you were just going to search by code, you would have no idea which vaccine was causing the problem. Is that correct?
If you search in your screen when you're in NextGen and put adverse vaccine, all of these pop-down menus will come out for viral, and it will have the COVID and will have the other viral. And then if you click on this, this will wind up in your assessment component, right? See how it says Coke. So I picked this is actually Rixie's screenshot, but I picked in my other patient's chart, the one that said COVID vaccine, which is the viral vaccine injury code T50. So COVID vaccine injury is a subtype of that. Although, you know, flu vaccines and COVID vaccines do have some similar conditions. The COVID vaccine, because it's messenger RNA, has the direct effects of it. And we can talk about the various categories of vaccine injuries later if you guys want. But that's just my point. It does go into the AMR. I think it's more about education. And like I told you offline, when I was doing my research, because I had gone into my own EMR chart in my own office to search these initially. And then over the last week or so, I went online to see what comes up when you Google this stuff online. You know, ICD-10, you know, and I was doing all the years, I was trying to make it easier for myself so it wasn't these annoying screenshots for this discussion. And I could get into ICD 2010. I can get into the ICD computer program, and I could get into 2012. But I couldn't get into online. It gave me a 404 error. It did not let me search in the internet these codes. I can only go into my own NextGen EMR system. Maybe you guys can find another way, which I found was really problematic because patients could probably go tell the doctors their codes if they can search it online. It was really kind of weird that I could get to the old systems. I hope I'm making my point.
Yeah.
I found that incredibly odd. So that's my point. Joel has a good point, but don't ever let a doctor tell you that they can't make the diagnosis, and we've initiated treatments for years. It needs to be better. Joel's right, but no one should be turned away because they just don't know about these codes. That's my biggest point. And if you want to talk about the different subtypes of vaccine injuries, we could talk about them because it might be interesting, but I might have bored you all at this point.
Well, Joel, what do you think? I mean, is it
Yeah.
practically speaking, the patient's none, you know, it doesn't really make a difference to the patient, or does it make a difference to the patient in terms of these
Well,
codes?
if they don't receive, it does make a difference to the patient because number one, they frequently get gaslit and don't get a vaccine injury diagnosis or a code. That's the first thing. Second of all, if they don't get a billable, reimbursable code, then the code is meaningless. You know, and again, I don't want to, I could expand this discussion. You know, we have discussions ongoing with the FDA and CDC and frankly, the NIH about expanding coverage for things like IVIG and trying to get increased, diagnoses that cover it. I mean, again, that's something I have meetings on every day, particularly IVIG. We're coming out with numerous different protocols that Dr. Bean and his team Dr. Mobeen Syed is our medical director, and he's coming up with a lot of protocols. And a lot of the protocols are going to end for recalcitrant neurological and autoimmune protocols, IVIG. And unless you have a CIDP diagnosis, in our world, you're not going to get it. That's where people fudge the diagnoses, but that's not fair to these people. So that's the first thing, because these codes do have direct implications to acknowledgement and definitely patient care. But Dr. Mavrakakis, I just want to ask you a couple of questions. So you're not disputing the fact that there is no COVID-19 vaccine injury specific code in the current system, correct?
I don't know if that's the right question. I'm saying that the T5 code, T50.599A, applies to viral vaccinations, and that is the only code available for COVID vaccine injuries, and it's been around since 2020. And just to belabor your point, what you just said is very important. So if someone's COVID vaccine injury, when they try to order IVIG, what is IVIG? So the autoimmune type of vaccine injury is all related to the fact that when you inject something into a person, the expected immune response, because that's our immune system, is we're going to react to foreign. And so a lot of vaccines are in the hyperimmune. Your immune system keeps attacking because you literally told it to. And the inadvertent consequences are actually expected because you injected foreign, and they fall typically on the IgG side and the IgE side, immunoglobulin E, which is the allergy side, which is what happened to me. And that's a lot of things that are missed. And I wrote a paper on that that's published on the IgE component of the cytokine storm in the vaccinated. But the point I'm trying to make is what Joel's point is that to get IVIG, which is immunoglobulins to attack the high immunoglobulins that are attacking your nervous system. It's like the antidote to what's attacking you by using the same system. And these are injections that cost tens of $20,000 a month, or more. The insurance companies want codes that meet the criteria for that diagnosis and treatment. And what Joel's talking about is that we need more codes that allow for that to be the treatment diagnosis. He's right on that, because it's a very narrow window right now, and more people would benefit from more specific codes that are autoimmune that no one even has ever heard of, so that they're not fighting with the insurance companies to get the IVIG for the plethora of autoimmune conditions. Post-vaccination myocarditis has been known for more than a decade, from post-vaccination flu vaccine myocarditis, which has an autoimmune component. Many researchers showed that IVIG can help with that if you get to the patient before they have heart failure. And the other crime against humanity is that we failed to diagnose the complication that we should have known, because literally it's called the vaccine adverse event reporting system, because vaccines have adverse events. And we know this. To pretend that there's no such thing as an adverse event for vaccine is to pretend that we don't understand the immune system in the first and second place. And so Joel is 100% right, because it is a pain in the neck to get some of these conditions treated for IVIG. The best process that I've seen through the local neurologist, I do a lot of diagnosing, and then they get turfed to neurology and the naturopaths, is plasmapheresis and the IVIG and other things based on what they're doing locally in my area, just a few of us. So it is very important, because insurance companies find ways to deny it. And who has $40,000 a month to get IVIG and other treatments? We're not just talking about that. So we do need better, but don't let a doctor tell you they can't code it, because that's absurd. And they're gaslighting them, and oftentimes they're not recognizing and giving them that anxiety code. Well, you know what? When you're in subclinical anaphylaxis, it feels like anxiety, but you're in a constant cytokine storm, which a lot of these patients are, and they are gaslighting them, and it's really another crime against humanity.
That's very true. So if you don't mind, I'm going to share my screen just a little bit and just go over a couple of things. Can you give me 1 second? Can you see this?
Yes.
Okay. So I just want to highlight again, I appreciate Dr. Mavrakakis, and I think what you've done is make what I would call as a workaround. Okay. You don't have a specific code for COVID-19 vaccine injury specific codes. And you've developed a workaround, which you're utilizing the T50 code, which I get many insurance companies are accepting. That doesn't necessarily mean they're accepting it as a billable diagnosis for something like ABIG, which, as you're correct, it's $10,000 to $20,000 for a month for us. This is the CMS master database for 2025 ICD-10 codes. And again, there's tons of different, vaccines here that are noted, some smallpox, all the other different ones, bacterial vaccines. I just want to highlight the fact that, again, if you look at T50B95A, and again, just to be kind of clear, the numbers mean A is initial, D is a subsequent visit, and S is sequela. But regardless, the T50B95 code is adverse effect of other viral vaccines. So other just means non-specific, not ones listed specifically in other T codes. That's the first thing I want to say. And it's because of this issue, which I've done a fair amount of work in this area. I did write a couple of op-eds, okay, and people can take a look at this. I wrote this. It was in Epoch Times. It was published by Trial Site News. It's an article that I wrote about why specific codes just for COVID-19 vaccine adverse events are important. Okay. And the last thing I want to show is this is actually right here. This is the application we made. Okay. So people understand, ICD-10. Again, what is ICD? International Classification of Diseases, 10th revision, clinical modification. How do we edit things? How do we add codes? How do we admit them? So just so all your listeners are aware, in November of 2022, I submitted a letter signed, maybe you might even have signed it, but signed by 25 physicians through Global COVID Summit. And I got no response. I want all your listeners to know that there is a code for long COVID. It was implemented in October 1st of 2021. Okay. So they have the long COVID code back in October 1st of 2021. We through React19 in November of 22 submitted a request, which was not even responded to. Okay. And now here we're at where here is, page one of, and I give a little history of codes that are used. So U12.9, you actually had that in one of your slides, Dr. Mavrakakis. So U12.9 was agreed upon in Germany to be just used for COVID-19 vaccine injuries. And I really want to say how important that was for Germany, because that really allowed them to really do much more population epidemiological research and analyses. So again, and then I'm going to go into a little history. U12.9, never used here in the United States, not approved. That's used in Germany, particularly in some other countries in Europe. And again, I explained kind of why it's important. I put literature, but here is really the request. This is the request that we're making from the CDC and National Center for Health Statistics, the request to add in a new code. So whether the number is U12.9 or UX, it doesn't matter. But I feel very compelled, and it's very important. You've developed a workaround, that's great. But I would ask you, Dr. Mavrakakis, what percentage of providers across the country, okay, do you think know that a T50 code, well, not ideal, that it exists, that they can use it? So my argument is probably about less than 1% of that COVID-19 vaccine injured people see a provider that has any clue about COVID-19 vaccine injuries, let alone any vaccine injury. And even if they acknowledge them and are seeing them, what percentage of American providers, physicians, nurse practitioners, extenders, do you think have any idea if I see a person with a COVID-19 vaccine injury, I'm going to use a T50 code?
Oh, I think it's very, very, very few, not even a percentage point. And I agree wholeheartedly that we need to pursue these codes. But the reason why I agreed to come on is to say that we need to educate our physician colleagues that vaccine injury codes have existed since 2010 or sooner, and vaccine injuries have been existing since a very, very long time and quadrupled after 1986 law HR 5546 that removed product liability from all vaccines and established the vaccine adverse event reporting system, for which $7 billion has been paid out before COVID for the vaccine injuries that you don't know about. And the PrEP Act, which was passed in 2005 and implemented and associated with the COVID vaccines and established the COVID countermeasure injury program, that you have to report your injury within a year, and gives product liability protection for vaccine makers and everybody. And if we remove the product liability protection, for which no product in the history of the United States, other than the Army Corps of Engineers, has this type of product liability, no one would have gotten this COVID vaccine, because the fact of the matter is that they knew in the preclinical trials that there were all these adverse reactions, and that there may have been fraud involved, which would invalidate the PrEP Act, because the mRNA that's synthetic doesn't just go away. The pseudouridine insertion site causes frame shifting, which causes 7 to the 328th power aberrant spike proteins, the DNA contamination. And so the point is that no one in the world got informed consent for this synthetic messenger RNA bioweapon, but we shouldn't even talk about informed consent. Do you know why? Because a bioweapon is not a medical procedure. And since government is tasked to provide protection of life, and physicians and healthcare workers are tasked to provide the protection of life, no human should have even been offered the bioweapon in the first place, which is the same concept with the informed consent for genital mutilation and puberty blockers in children. There is no informed consent because we're supposed to always first do no harm. So Joel, I think it's important what you're doing 1,000 times over. My point is related and different. There are codes, and I don't think anybody knows about them, and that's why I agreed to come on the show, because they need to make them, because this is the crime against humanity part 2, right? Because when the vaccine was coming out, I looked for these codes so that I would know what diagnosis codes I was going to use. And these codes were coming out around the time, I don't remember the timeline, but they've been there since 2020, the other viral vaccine codes at least. And so it could have been diagnosed from the beginning, and then all of these people could have gotten treatment. The myocarditis could have been treated early, and we could have not had as much harm as we did, plus stop giving people bioweapons, and we might be better. So that's my take. I wholeheartedly agree that what you're doing needs to be done, but we have to tell people that we have something. And I agree no one knows about it, which is why I agreed to come on the show.
So again, I think we're very much in agreement on that. I mean, with regards to the workaround that you're doing is great, right? And it's better than what a lot of these vaccine injured people get, which is just gaslit and thrown out and told they're crazy, basically. I get that. And I also understand that education is important. And again, if anyone listening to this, I mean, there are codes. I hear you, there are codes, but they're not specific to COVID-19. And my hope is that by October of next year, this new COVID-19 vaccine injury specific code is out, and there's they allow us to do subcodes that really delineate the injury more. We can be studying them more often. But you also made a good point. Part of it's going to be education, right? And expectations from our federal regulatory agencies. So they need to communicate, okay, this. I give you credit. You went above and beyond, studied this, evaluated this. Again, I agree with you. Probably less than 1% of providers would do that, spend their time to understand that, let alone would understand it, because they just don't acknowledge the injuries overall. You brought out some other good points about lack of informed consent. I totally get it, okay? And the PrEP Act, remember the public health emergency ended in 2023. The PrEP Act immunity by Becerra's order has continued through December 31st of 2029. That's immoral, unethical. I have a federal lawsuit still against Biden, Becerra, and Carol Johnson for violating my 5th and 7th Amendment rights, basically preventing me through the PrEP Act of due process and jury trial. So again, that's kind of getting to the heart of what you're talking about. Now, will my lawsuit be thrown out? Probably. There was a similar lawsuit in Louisiana that was filed for lack of standing, but that's really not because it didn't have merit. But I don't have the only lawsuit, but again, there's certainly a lot of issues going on. I'm not trying to, I don't want to get too far in the weeds, but I agree with you on those other issues, 110% of lack of informed consent. But I do think that I hope that any medical provider listens to this is certainly a little bit more aware of the coding and why it's so important. And my hope is that within 1 year from now, it will not be as muddy, and it'll be clear that when a patient presents, they get diagnosed, they get a COVID-19 vaccine injury diagnosis, and then they have subcodes that go into very much detail. Is this a neurological injury? Is this autoimmune? Is this an inflammatory issue? Is this a clotting issue? Is it an MCAS, IgE issue? All that other stuff. But we're not there. And we really.
Uh-oh, where did Irene
Uh-oh.
go? Well,
Irene.
one quick question. Do you think insurance companies will start reimbursing once there is the code, or are they going to find a workaround?
So no, this is why, Mary, this is so complicated. So, okay, so I know I'm going back to IVIG, but this is one of the biggest issues because we have Dr. Bean, who's going to come out with a bunch of protocols for neuro and autoimmune within the next 1 to 2 months. Okay. And at the end, for all the people with the recalcitrant neuro and autoimmune issues, IVIG is going to be one of the big things. And there's plasmapheresis, apheresis, but IVIG will be one of the big things. So the code is only one part of the equation or one part of the answer. Okay. So what I will tell you is I went to see, I'm trying to get IVIG. Denied, I appealed, got denied again. Right. And why? Because I don't have a diagnosis that the FDA has communicated to the insurance companies that is reasonable use. So my neurologist says this is kind of ironic because what I have, the clinical standard of care is where I'm at is IVIG, but the insurance standard of care is not. So what do we need? Because the insurance company will always rely on what the FDA says. Okay. And the FDA has not made any comments. And that's why I was just back out, last week, and we'll be out in January to try to get something from the FDA to put either, so a national clinical guideline is what you're looking for, okay, to say that IVIG, there's a national clinical guideline that it is used for, let's say, transverse myelitis. And that's just an example. Right now, that national clinical guideline doesn't exist. But if it did, that's basically FDA's statement saying if you have this diagnosis, IVIG is the treatment for recalcitrant issues. Right now, there is no national clinical guideline. The problem, Mary, is a national clinical guideline to develop one, right, could take 5 or 10 years. We don't have that time. We're coming out with these protocols. And if we're sending all these people protocols and their providers protocols that they can't get, doesn't look too good for us either, right? Not good for the people, but not good for us promulgating protocols that they can't get. So what we're going to the FDA with and the CDC with is help us. Okay, we need something, emergency use authorization, compassionate use. We need some avenue around the standard, 5 to 10 year national clinical guideline to get these people IVIG. Yes, the diagnostic code is important, but it's only one piece of the puzzle.
Why is it so expensive? Do you know?
Well, it's a pooled blood product, from hundreds of people, and I don't really know. I actually tried to call myself to the 5 main manufacturers, and one company, CSL Behring, called me back, but then kind of blew me off. So now we're actually using CMS, and we have one of the deputy directors of CMS who's contacting them and trying to get them to the table. Okay. Because we could expand if we were to put out these protocols to the world, we potentially could increase the demand of IVIG like dramatically. So we do have an initiative, and I just met with the CMS head 2 weeks ago. And they're going to hopefully foster some of these meetings because obviously they don't want the manufacturers don't want to come to the table to meet some little person from an advocacy organization, but they'll meet somebody from CMS. So we're waiting for those conversations.
How many treatments do people normally need?
Sometimes it's short term. Some people are on them for, long term. I mean, maintenance. So typically people get a loading dose, and your loading dose is kind of dependent on your diagnosis. An autoimmune loading dose may be lower, and a neural type diagnosis may be higher. But regardless, it's a big loading dose. And then some people every 4 to 6 weeks are getting a maintenance dose. Fran Dressen, my co-chair, has been on it for years.
Wow.
Sorry.
Yeah, go ahead.
No, I think we would be remiss if we didn't talk a little bit more about the different categories of vaccine injury and preface this all by saying that IVIGG and plasmapheresis are a very specific type of treatment for very specific types of vaccine injuries. And depending on your genetic predispositions, prior vaccine injuries, and other medical conditions, your vaccine injury could be from a plethora of different types of sources and oftentimes multifactorial. For flu vaccine and other vaccine, the injuries typically can be on the autoimmune birth both IgG and IgE, but then there's also the direct effect of what's in the vaccines, adjuvants and excipients. There's also the direct effect of the consequences of what's in those different vaccines, depending. And then in some patients, you go on to immune exhausting, like hypoimmune states, and then other confounding factors. Because really, it's a disruption in your biochemical order and in your microbiome, and becomes a state of its own disease. For COVID vaccines specifically, because since it's injected into your body that went into your ribosomes that made you a spike protein producing factory, which is one of the most dangerous parts of this. It also had other adjuvants and excipients that we also talked about, and then the DNA contamination. So the vaccine injury could be related to all of those things, whether or not you're still producing spike, all the consequences of still producing spike. But then it's also the fact that vaccines premise on the fact that we believe that the immune response is innately meant to react to foreign. And we can't pretend that injecting foreign is not going to cause inadvertent consequences. It's actually expected. If you don't believe that there's inadvertent consequences to vaccines and synthetic messenger RNA injected into you, then you don't even accept the concepts of that premise.
Let me just posit this. So you're injecting IgG, foreign IgG. Doesn't that elicit an immune response?
You can.
But
yeah. Okay. So that's the point of this IVIGG. So I don't want people to go away with everybody needs IVIGG, because there's a risk benefit analysis and people should be getting informed consent. So the people with the hyperimmune immunoglobulins, antibodies, attacking their central nervous system and having, MS-like symptoms, right? Progressive neurological deficit and pain, right? And your IgG is really high.
So you can measure that on a lab and you can see the IgG levels very high.
You can measure nonspecific IgG levels, and Joel will talk about, I'm not sure if they measure COVID specific IgG, but you can measure specific.
I've been measuring spike protein antibodies, and yeah, I mean, sky high.
Right.
So, but I'm just wondering, do we have a test that say, okay, yes, you need IgG, or you will benefit from IgG. Can you do a lab test to predict that somebody will respond well to it?
Right. So you just said you're measuring so currently, right? Excuse me, I misspoke earlier. We can't measure spike directly yet. That assay is not out yet. There are people working on it now as we speak. You're measuring antibodies to spike, right? But there's also antibodies. There's a whole category of IgE, GG, and IgE to all the different subcomponents of what was injected into us, not just spike. Do you see?
Right. And I do that. I do the non-specific.
You do a total.
I do a total, but I don't see that as much of a problem as a spike protein antibody. I'm just wondering, can clinicians use the IgG test or maybe even the spike protein antibody test to determine who might respond to the IV IgG?
Right. So the local neurologist that I work with, if they have really high IgG levels, like antibody levels, global, high levels, and they have symptoms of transverse myelitis or CIDP and other concurrent clinical diagnoses. He's been doing IV IgG for those patients and sometimes plasmapheresis, right? But again, there's side effects to these treatments, right? So we can measure the antibodies to the spike. We can't measure how much spike people have themselves. And a lot of the elevated immunoglobulins, right, are to other things we don't even know what they're
Right.
to, right? We have no idea, right? So you have a total high level of immunoglobulins, right? And then we're measuring the spike ones. But then there's all this other stuff that's attacking our system because it's gone haywire, because they've been injected, and because also you're producing spike in some patients. And then on the allergy side is immunoglobulin E, which releases histamine through mast cell binding. And there's multiple studies, even before COVID, that the flu vaccinated had an IgE or allergy component of the cytokine storm and developed immunoglobulins to the flu antigen. And during COVID, there's many studies that show that there's an IgE allergy mast cell component. And if you think about
Can you measure that? Is that,
you
I've
can
never
measure,
seen that test. Is that
you,
available?
you can measure total IgE. And there's a study in 2020 from the British Journal of Medicine, and it was a specific study in flu vaccinated patients who were hospitalized, and they did a special test to measure IgE to the flu viral antigen, and it was high. Is that readily available in the United States? I have no idea. I would say I don't think so, but I'm not going to misspeak. I have no idea. But you can measure total IgE, and you can measure
Well,
eosinophils, and you can.
I hate to keep interrupting, but things are just keeping popping in my head because I do IgE testing all the time for my allergy patients. So it doesn't seem like it'd be that hard to do an IgE test for the flu shots and the COVID and the spike protein. And I don't know, that seems like a logical, easy thing to do.
Right. So I don't know if it's readily available. I know in this specific study that found IgE to the flu viral antigen in the flu vaccinated. So my paper in the AAPS in June talked about the IgE component of the cytokine storm in the vaccinated. And I have about 17 citations that the researchers found during COVID, that a component of the cytokine storm in the vaccinated was IgE. So think about it. In the beginning of COVID, a lot of the really sick people were heavily flu vaccinated, right? Healthcare workers, military, and nursing home patients, okay? And I have special interest in this because my vaccine injury was recurrent anaphylaxis for years. Like, I was a nightmare. I was your nightmare if you were my doctor. You would have been like running away from me. It was bad. And gastrochrome, chromoline sodium, which a mast cell stabilizer, saved my life. I went to Hopkins, and that's what they put me on, and some other things. So COVID and flu have some antigen similarities, and IgE can be nonspecific. For example, latex allergic patients, which is what I am, cross-react to kiwi, avocado, walnut, and banana because it's a similar structure, right? Similar. So IgE cross-reacts, just like IgG. That's how we're into the situation with the autoimmune component of the IgG, right? So I'm trying to get to my point. It's a very important point. They saw in the COVID vaccinated patients high levels of IgE, histamine, tryptase, like all these kind of things, right? And they sometimes called it like the vaccine injury to have, idiopathic mast cell disease or whatever. And I had a long discussion with Peter McCullough a couple of years about this, and he is using gastrochrome for some of his allergy component of the vaccine injured. My point is that it's specific. If the article in 2020, flu vaccine causes dengue-like illness, they found IgE to the flu antigen because of repetitive injections causes sensitization from Charles Ricketts' original study in 1913 on the origins of anaphylaxis. There's a possibility, I haven't proven this hypothesis, that a lot of the original patients who had a higher cytokine storm in the beginning of COVID was because they had IgE to flu from 20 years of flu vaccines, and those IgE were cross-reacting with the COVID antigen before the COVID shot came out. And then you do the COVID shot, and they're making IgE to that because we don't have to prove this point. This is basic human biochemistry. We understand that we will make IgE to things injected to foreign. It's the same concept as some people who get injected with bee venom develop anaphylaxis and some people don't. But we don't get anaphylaxis to things that are not injected into us typically, right? You know, people are not anaphylactic to grass. They're allergy, maybe bad allergy, but they're not anaphylactic. People are allergy to latex because of the foreign exposure in the body, and some vaccines actually have latex stoppers. That's a whole other can of worms.
What about peanuts and
peanuts? So the thing is that after 6 years of research, I found a book by Derek O'Hagan on vaccine adjuvants and excipients, and they list 4 pages of the current vaccine adjuvants and excipients used in the United States as of the writing of this book. And it lists legume oil, peanut oil as a currently used vaccine adjuvant and excipient. And I sent this to Bobby and Lynn a few months ago. And my hypothesis is that it's still in there because it doesn't make sense otherwise. And there's a big article about Merck in like 10, 20 years ago putting peanut oil in the flu vaccine. It's a New York Times article. So it was put in there once. And I think it's still in there because that's what makes sense to me, because the book about vaccine adjuvants and excipients by Derek O'Hagan says that under vehicles, they use legume oil still. And we know that even though the CDC adjuvant and excipient lists various components, there's still other components that are not specifically listed that are considered proprietary and things like that. So I can't prove it, but I think that there's still peanut oil, legume oil, and some of the vaccine adjuvants and excipients based on this vaccine adjuvant textbook.
interesting, very interesting.
Yeah, that was great.
I'm going to get the textbook. Hold on.
The other thing that I wanted to bring up when you talk about, I break down the injuries to the COVID shots really in 3 big pathophysiological categories. One is the anaphylactic and allergic group. Second is the autoimmune group. And third, in my opinion, is the inflammatory group. This inflammatory group includes myocarditis, blood clotting, et cetera. Autoimmune is somewhat self-explanatory, and it seems like there's a heck of a lot of molecular mimicry going on. But just going back to a little bit about testing for MCAS and allergies, I totally hear you, IgE levels. I totally hear you about histamine levels. But one thing I've learned too is IL-6 blood levels can be indicative of MCAS. And then the other thing is urine prostaglandins. So urine prostaglandins can also be another marker of MCAS.
Is that a 24-hour urine or just a
spot urine test?
But my point that I want to make about MCAS, it's not idiopathic MCAS. It's because you're injecting people with stuff, they're going to the allergy side and they're having perpetual release of mast cells because they have IgE specific to the stuff that's been injected to them, because that's the mechanism. So it's not idiopathic. That's like the point that I try to belabor all the time. And I had this conversation with McCullough because it matters, because we're not supposed to get so much stuff injected into us. So this is the book. It took me, I don't know, 4 or 5 years to find this book.
Easy reading.
I have a hard copy of it.
It's a cure for insomnia.
You have no idea. Remember, I was in recurrent anaphylaxis fighting my insurance companies for EpiPens. I had nothing else to do, but you know.
Is this something you can get off of Amazon?
There are some copies available, and it talks about all the listings. I have a screenshot of it under vehicles. No one's going to be able to see this. It's peanut oil right here in this book. And it says adjuvants administered to humans. And there's a clip from Paul Offit saying years ago, even if there is a little peanut oil in vaccines, that's not enough to cause a problem. Bullshit.
Yeah.
He's on record saying that, and it's very weird that he said that. Don't you think? So, according to this book, it's in there, but it's not listed on the each item in the vaccine adjuvants and excipients list in the CDC. I sent this to Lynn Redwood, uh, I don't know, like a year ago or so. So they have it, and you add that plus aluminum, which makes you more likely to develop an allergy. So the point is that the allergy side of this is very important. And my paper in AAPS in June talks about gastrochrome. And then I just want to make one more point. I am working on something behind the scenes that I can't really talk about too much, but we need clinical trials for vaccine injury treatment, all the spectrums of things like that. And Joel, you might be interested in this, and we can talk offline. And working on getting research grants and clinical trials with a bunch of doctors to start having clinical trials for vaccine injury treatment on all the things that we are talking about. I don't work for Health and Human Services. I'm just a regular doctor doing this on the side, but I have about 35 doctors working with me. I'm just starting on project managing this. And so if you or other doctors are interested in this project to get together to start doing multi-center clinical trials for vaccine injury treatment, while you get the codes for us so we can get stuff approved because it's very important, I think that we can prevent crime against humanity #2. The first one was injecting a bioweapon from continuing to happen, which is the complete neglect, failure to diagnose of millions upon millions of vaccine injured people. And as someone who's 95% recovered from a vaccine injury, I have to do this. I think about this all the time. It's actually quite annoying to the people around me, but we have to help these people, including you, Joel. So I'm so sorry that you were vaccine injured. I'm so sorry you were coerced. I'm so sorry that you were not provided informed consent. I'm so sorry actually that no human should have injected a bioweapon into you, because this should have never happened. And I'm so sorry that that happened to you, Joel.
Well, I very much appreciate it. Obviously, Dr. Mavrakakis, I'm very sorry that you were injured also. So I really appreciate that. I just want to make a couple of comments. Definitely, let's have a conversation offline because we are having conversations within the NIH. And again, what I say is a lot of talk, not enough action. And I'll quote a pediatric orthopod I used to work with. He said, too much talk. When he actually was horrible with parents. He loved taking care of kids as a pediatric orthopedist. And he said, too much talk and not enough operating. So one of the things I learned is again, a lot of good stuff going on in DC. You're there literally now every month. We have a lobbyist there that's there half time who lives in DC. So let's have some conversations, because there is ongoing conversations of what do we think needs to be done retrospectively and what needs to be done prospectively when it comes to these injuries. So let's have some of those conversations. The other thing I want to just make a little clarification. You talked a little bit about, a lot of the autoimmunity being hyperimmunity. The reality is I view it in the COVID vaccine injury that I see, it's really autoimmune dysregulation, because some of them are hypoimmune. And it's
No,
really
yeah.
quite bizarre. And it's not just hyperimmunity, molecular mimicry, neurological attack. Some of these people are significantly hypoimmune. So it's bizarre, which only highlights the fact that we need a heck of a lot more information and data.
Well, if you inject the simian 40 virus that was also in the hepatitis B vaccine trials in gay men and IV drug abusers before AIDS came along, you're going to have a lot of immune problems. And the hyperimmune, and then we have the immune exhaustion, which you made a good point, but there's a big component of that. And there's a lot that I still have to learn. But yeah, it becomes almost like a vaccine injury COVID's kind of situation, unfortunately. And it's really a very horrible thing that happened to humanity. And I'm really glad that you belabored that point as well. And immune dysregulation is also a really good term to use. And I will use that more. I like that term.
Well, this has been wonderful. Tell Dr. Wallskog, tell everybody how they can best help. I know you're the co-chairman of React19. And actually brag about how much you guys have helped compared to the government. I love this Stark
so let me,
contrast.
so the government has really sucked at helping this population. So again, so just everyone understands, you have a public health emergency. A public health emergency, which was enacted, whatever, in 2021, maybe I can't remember the exact date, but it enacts the PrEP Act, which gives everyone, blanket immunity. Okay. And I understand, we can sit here and debate about whether or not there's a public health emergency, but let's just assume, there really was one and they really needed to declare a public health emergency, which they did. The PrEP Act strips Americans injured by the COVID-19 shots of their constitutional rights, Fifth and Seventh Amendment, constitutional right to due process and jury trial. Okay. I get that. Okay. Something was so, I disagree that really there was a public health emergency. I think our response to it was exponentially worse than the pandemic itself. That's my personal opinion. But regardless, let's just say there is a public health emergency, and that's the PrEP Act. It strips us of our rights if we get injured. The counter to that is there's supposed to be a safety net. A safety net that if you get injured, and Dr. Mavrakakis is correct, this was never a vaccine. It was a countermeasure. Okay. It was never approved through normal regulatory process, so forth, so forth. So if you're injured by one of the COVID shots, your only financial remedy is to apply to the CICP, which is the Countermeasures Injury Compensation Program, not the Vaccine Injury Compensation Program. The Vaccine Injury Compensation Program has been around since 1986. It's not a great program, but it's funded by an excise tax, 75 cents per vaccine dose from pharma. If you get injured, and it has about a $4 billion surplus in the bank right now. So if you get injured, it also covers attorneys. It's a 3-year time to file. And it's this program, which I would say needs to be updated. It hasn't been updated for inflation since 1986. It's not great. I've talked to anybody who wants at CHD who have an injury to one of their child. It's not a great program, but it's 1,000 times better than the CICP. The CICP doesn't cover attorney fees. It's a black hole. You apply, you don't know what standard they're using. Okay. It's, get 1 year to file. And most of us don't even get a diagnosis within a year. And then let's talk about the awards. It's a 98.3% denial rate. Okay. I was denied. It took me 18 months to get a denial. I appealed right away. It took me 14 months to get rejection of my appeal. Okay. Now, but let's talk about the 42 people last I looked that were compensated. 42 Americans for their injuries to COVID shots were compensated. There were 2 large awards, one for $2.5 million, which we know the family who actually has received the money yet, and the other person, which was a myocarditis injury and I think possible death, was $370,000. Well, let's take out those 2 awards. So the other 40 people shared an average of $4,200 for their injuries. It's a pathetic program. Okay. I read the entire budget of HRSA, which is Health Resources Service Administration, which houses the CICP for 2025. I read their entire budget. But what it gets down to is for 2025, they budgeted $10 million to the entire CICP. Other countermeasures aren't just the shots, ventilator injuries, clonals, all those other things, but they allocated $10 million to the CIC program. Of that, $99 million was for administrative costs. $1 million was set aside for the 2025 budget for injuries. It's insane. Okay. Now, within React19, we have now given out almost $1.5 million to over 200 people now. Again, I wish I could give out, we give out medical grants up to $10,000 to Americans injured by the shots for uncovered medical expenses. You and I know a medical bill, $10,000 is a drop in the bucket, but these are people that are the worst of the worst. They're living in their car. One person was considering going to the Pegasus Clinic, which is the active euthanasia clinic in Switzerland. These are people where $10,000 literally can be life-changing. We got involved with actually a 8-year-old that was admitted to a psych ward for 3 weeks up in New York. We got involved, first of all, got her out. She was diagnosed with a functional neurological disorder. We hooked her up to start getting IVIG. We got her out of the hospital, got a real diagnosis, which is CIDP. Literally 3 months later, she was walking out of diapers, and within 6 months, moved back to school. Wow. And that started just with the CARE Phone grant. again, it was just the start of, but we don't just give people money. We follow up with advocates, which is nurses and social workers, that really get them into, providers like um, Irene that, really have an idea of available diagnostics and treatments. So um, any listeners, I mean, we are at the end of, if you go on our website, it's www.react19.org/care. We are in the end of the year. This is our shot campaign, and we had two very generous donors, each agreed to donate up to $250,000 in the matching campaign. So we're trying to raise $500,000. By the end of the year, we're at about 370,000. So if we can get another 130,000, that will then be doubled by these wonderful matching donors that we have. We have one corporate sponsor who owns a real estate insurance company of $10,000, but obviously, our donors are mom and pop. Our average donor is $82. Okay, it's these big corporate donors, because they don't want to have anything to do with us, unfortunately, because the issue is so polarized. Again, as you all know, it's starting to change. So anyone that's willing to take a look at our website, consider donating. We greatly appreciate it. It's www.react19.org.
Wonderful.
Thank you.
Wonderful. And Irene, where can people find you?
So most of the time you can find me on Twitter at Irene Mavrakakis. That's probably the best way to find me. And we can go from there. I'm not going to give out my research email, but they can reach out to us and if they're interested in some of the projects. I'm the host of Liberty Speaks with Dr. Mav podcast. It's at National Speaks. It's a small podcast, just getting started. It's on Rumble, Spotify, and Apple.
Right.
And I just want to make one point. The answer actually is freedom, more freedom, separation of medicine and state. What does it say in our Declaration of Independence and Constitution? We hold these truths to be self-evident, that all men are created equal, that they're endowed with certain inalienable rights, including life, liberty, property, and the pursuit of happiness. And the thing is, government is tasked to protect life, liberty, property, and the pursuit of happiness, and it was the destroyer of these things. You have a right to bodily autonomy that's God-given, the right to choose what's put into your body, and those rights are enshrined in our Constitution, and the government works for us to protect those rights. And so being coerced or forced into taking any medical procedure is against the standard of care, against the Helsinki Code of Ethics, the Belmont Report, a violation of the informed consent tenets. But in this particular case, it's egregious because it was harmful. A bioweapon was known to not prevent transmission, had serious side effects, and that was known in the preclinical trials before it was launched upon the general population. So the point that I would like to make is the answer is more freedom, removal of government out of healthcare, remove quality measurement payment systems, remove all of that, have a true free market, and let patients decide what it is that they want for their health care. And by no means tie our ability to have life and property and liberty to a forced medical procedure. COVID mania tyranny can't happen again because it's an example of our failing constitutional republic that's functioning like a captured oligarchy, where the pharmaceutical industry and other industrial complexes are controlling our government, and we the people have not been really free. So get involved locally. I'm involved in the Republican National board for the Republican Liberty Caucus. I'm on the board and the Delaware coordinator. If you're interested in expanding the Republican Party a little bit more towards the Constitution and freedom, reach out to me. And remember, the government works for us. Don't ask anybody for permission.
Well said. Well, thank y'all so much. And we'll hopefully rile up the masses to get behind. The bottom line is we need some codes or a code, a single code. And it's not too much to ask. They made one for long COVID. We just need one now for the COVID vaccine injured. So thank y'all so much. It was a great debate.